Okay, welcome everyone to the session on cannabis and impaired driving. We'll be here for the next hour and so. We have 5 presentations today. We're going to start with Christine Wickens. I'll ask people to, presenters to introduce themselves briefly and then get right into the presentation. You'll have 15 minutes. I'll give you a warning when your time is coming to a close. And if there's time for any questions at that point, we'll look at the Q&As and see if we can answer some of them then. If we have time at the end of the entire session after everyone is presented, we will entertain questions at that point. So, Christine, you're on.
Thank you. See if I can share my screen here. Well, that didn't work. Let's try something else. Let's try that again. Well, nothing like starting off the session with a technical glitch. Try it one more time.
There we go.
Perfect. All right. Nothing like a slight delay. Well, thank you everyone for having me. It is a pleasure to be speaking today, and I'll be speaking on driving under the influence of cannabis among recreational and medical cannabis users. So according to the 2020 Canadian Cannabis Survey, 27% of Canadians aged 16 years and older use cannabis for non-medical, that is recreational purposes, and 14% use cannabis for medical purposes. Now, relative to recreational only users, those who use cannabis for medical purposes are typically older, they have lower income, poor health and mental health, they report more frequent use of and problems with cannabis, but less use of and problems with alcohol. And in a sample of adolescents, medical users also perceive cannabis as less harmful. Findings from many surveys suggest that recreational cannabis use is common among medical cannabis users. And so for purposes of analysis, many studies have grouped individuals who use cannabis for both recreational and medical reasons with medical-only users. Many of the factors that differentiate medical and recreational cannabis users have previously been identified as correlates of driving under the influence of cannabis. So for example, the odds of driving after cannabis use are greater among those experiencing mental health issues and those who report problems with use of alcohol or cannabis. Likewise, perceiving a higher intoxication level as safe for driving is correlated with intention to engage in and frequency of driving under the influence of cannabis. Now, although we've identified many differences between medical and recreational cannabis users, few studies have explored driving-related differences between these two groups. Color et al. 2018 recruited cannabis users in the US aged 16 plus years for an online survey to assess beliefs, practices, and experience of incidents related to driving under the influence of cannabis. Descriptive analyses comparing participants who reported using cannabis for recreational, for medical, and for both recreational and medical purposes found no differences in the percentage of participants who believe that driving under the influence of cannabis is safe, who reported engaging in the behavior, or who had received a ticket or been involved in a collision associated with the behavior. Lloyd et al. 2020 examined data from the National Survey on Drug Use and Health and found that the relationship between purpose of cannabis use and driving under the influence of cannabis varied as a function of sex. Among females, recreational users were more likely to drive after cannabis use than were medical users, whereas among males, those who use cannabis for both medical and recreational purposes were more likely to drive after cannabis use than were the medical-only users. So given the paucity of data, the current study sought to examine this prevalence of driving under the influence of cannabis among medical and recreational only cannabis users, adjusting for other relevant factors. The current sample was derived from the 2014 through 2019 cycles of the CAMH monitor, which is a repeated cross-sectional telephone survey of Ontario adults aged 18 years and older. The survey employs random digit dialing methods via computer-assisted telephone interviewing, which allows the survey to access landline and cellular telephones, including newly listed and unlisted numbers. And the response rate for this period of data varied from 28 to 45%, which is comparable to other recent Canadian alcohol and drug use surveys. The overall sample included 1,084 respondents who reported using cannabis and who reported driving a motor vehicle in the past 12 months. The key outcome variable was driving under the influence of cannabis in the past year. So specifically, respondents were asked during the past 12 months, have you driven a motor vehicle within an hour of using marijuana or hash? The main predictor variable was purpose of cannabis use and was measured by two survey items. First, respondents were asked, how often, if ever, have you used cannabis, marijuana, or hash during the past 12 months? Second, those who indicated any use of cannabis in the past year were also asked, in the past 12 months, have you ever used cannabis, marijuana, or hash to manage pain, nausea, glaucoma, the symptoms of multiple sclerosis, or any other medical condition? Responses to the two survey items were then combined and recoded to create two groups. So we had recreational cannabis use only, and then we had medical use with or without recreational cannabis use, which we will hereby refer to as medical users. Now, a group dedicated to medical cannabis use only could not be created due to limitations of the existing items in the CAMH monitor survey. However, as I noted earlier, grouping medical only users with combined purpose users has been fairly common practice in the existing literature. Other predictive variables in the analysis included demographic characteristics. So we had sex, age, marital status, education, and income. Weekly driving distance was included as a control for differences in exposure. Hazardous or harmful drinking was measured by the Alcohol Use Disorders Identification Test, or the audit. General health was measured by asking, in general, would you say your health is excellent, very good, good, fair, or poor? And the mental health item was measured in a similarly worded way, and responses for both of these items were converted to binary scoring. Binary logistic regression analysis was used to assess the association of medical cannabis use relative to recreational use only, with driving under the influence of cannabis after adjusting for related covariates. In light of the significant interaction that was identified by Lloyd et al. 2020, which I described earlier, we did a subsequent regression analysis to look at the interaction between sex and purpose of cannabis use. Pseudo maximum likelihood estimation and Taylor series linearization were implemented using the complex sample module in SPSS version 20. And so all of the estimates and all the statistical tests were corrected for the sampling design. With the exception of the income variable, item missing data were excluded listwise from all analyses. The weighted sample was used when reporting percentages, and estimates are representative of the population surveyed. Okay, so in presenting the results, I'm going to focus exclusively on those variables for which there is a statistically significant finding, but all of the output is available in the conference proceeding if you're interested. So in the current sample, 65.5% of respondents reported recreational only cannabis use, and 34.5% also reported medical use. The overall prevalence of passenger driving under the influence of cannabis, excuse me, was 15.7%. The adjusted binary logistic regression model accounted for close to 13% of the variance in driving under the influence of cannabis. Three variables were statistically significant, including our primary variable of interest. So after adjusting for the other potential covariates, medical cannabis users had almost 4 times greater odds of engaging in driving under the influence of cannabis than did the recreational only users. That separate binary logistic regression analysis that we did examining the interaction of sex and type of cannabis user in predicting driving under the influence of cannabis was not statistically significant. Okay, so our results indicated that medical users had nearly 4 times the odds of engaging in driving under the influence of cannabis compared to recreational only users. Now, this is in contrast to the findings of Cutler et al. who found no difference between medical and recreational users, and in contrast to the findings of Lloyd et al., who reported a significant interaction between sex and purpose of use. So the divergence in our findings from those of Cutler et al. And Lloyd et al. May result from differences in methodology. So both of the other studies distinguish between medical only and combined recreational and medical cannabis users, whereas these two groups were actually merged in our study because that was the only way that we could analyze them. But as you know, as I said, that's fairly common practice in other studies of this population. As well, the Cutler et al. Sample was recruited through word of mouth and online advertising, and therefore was not population representative. It's always important to acknowledge limitations, and I have listed a few of these here. Survey data are correlational, barring cause and effect conclusions, and they are based on self-report, so they may be subject to social desirability bias. However, self-report measures of alcohol and drug use have been shown to be valid in general population samples. Eligible respondents declining to participate may have introduced a non-response bias. However, existing research indicates that survey data with response rates as low as 10% can actually generate highly accurate estimates. And finally, the survey excluded non-English speakers and individuals without telephone access, which included those who were homeless, institutionalized, or in the military. However, this is mitigated somewhat by the fact that there are likely few drivers among the homeless and the institutionalized. So, you know, in order for interventions designed to reduce cannabis-impaired driving to be effective, they must be appropriately targeted. And recognizing the relevance of purpose of cannabis use to driving under the influence of cannabis, future education campaigns might therefore consider targeting medical users. Clearly, I think further exploration of the beliefs and perceptions of medical users regarding the risks of driving under the influence of cannabis is needed. We need to know more about reasons for engaging in the behavior, frequency of driving under the influence of cannabis among this population. All of those things would inform the content of education campaigns. For those medical users who obtain their cannabis through prescription, there may be a role for physicians, pharmacists, or medical dispensers to educate patients about the risk of driving after cannabis use. It will also be important for future studies to assess differences in collision involvement between medical and recreational cannabis users. It may be that although medical users are more likely to engage in cannabis-impaired driving, they may be more likely than recreational-only users to opt for products with lower THC levels, thereby potentially reducing collision risk that's associated with cannabis use. As noted previously, there's actually strong evidence to suggest that medical users use cannabis more frequently and in higher quantities than recreational users. And many believe that frequent cannabis users, including more medical users, can drive safely after cannabis exposure. And although the results are mixed, there is some experimental evidence to suggest that frequent cannabis users experience less impairment than occasional users when they're administered a fixed dose of cannabis. But outside of the laboratory, we don't know what happens. It may be that frequent cannabis users may use larger doses of THC than the occasional users to offset any tolerance of subjective effects, resulting in a more equivalent impairment when operating a motor vehicle. And so with all of these questions about what really happens, I think it's pretty clear that we still need more epidemiological and experimental research to get a better sense of how to address the issue. And so I will stop there. I will thank you for your kind attention, and I will welcome any questions that you might have either now or at the end of the session, whichever Doug thinks is best.
Thanks, Christine. We have one question here. We got time for you to answer it quickly here. Any investigation into the source of cannabis that is prescription or recreationally obtained, and the types of cannabis that's dominant, either THC or CBD? Is there any information on that?
There is. So there have been a number of surveys that have asked users where they're sourcing their cannabis, whether it's from black market sites, whether it's from legitimate sources. There are also surveys that have looked at for medical users. Are they, why are they using medical cannabis? Is it for pain? Is it for anxiety or for treatment of depression? And they are finding differences in whether it's a THC dominant strain or a CBD dominant strain and so the type of strain tends to vary with the type of illness or the type of condition that they're using the cannabis to treat. And so as we move further with this line of investigation, those are some of the questions that we want to look at. So, is there an effect of THC on driving amongst those who are using it for pain or using it for anxiety and depression? Because again, you may actually find that there's but I hate to say it this way, and it's not coming out well. But if we know that pain impacts driving, we know that anxiety and depression impacts driving. Does a particular type of cannabis affect the participant, the individual's driving? Does it improve their driving over and above what they would have with pain or with anxiety and depression? And so those are important questions that we will have to look at, many of them experimentally with driving simulation as we move forward with cannabis research in Canada.
Okay, thank you. We'll move along to the next presentation now. We have Nick Cristiano and Shauna Meister from the Canadian Centre on Substance Abuse and Addiction.
Sorry, everyone, I'm just trying to. It always goes well in the rehearsal. All right, thank you, everyone. So today I'm presenting with my colleague, Nick Cristiano. Nick is, pardon me, a postdoctoral research fellow with CCSA, and I'm a senior research and policy analyst. So today, my colleague Nick and I, we will be talking about perceptions of drivers and when they think it is to drive after using cannabis. We'll begin by briefly providing context on the scientific evidence on when it is safe to drive. We'll then give an overview of the data set, research methods, discuss some of the results of the study, and finish with implications of and a few recommendations on what can be done. For those of you not familiar with CCSA, we were created by an act of parliament to provide national leadership to address substance use and addiction issues. We are primarily funded by Health Canada, but we are not a government agency. We are an independent and nonprofit organization. So we conduct evidence-based research to broaden expertise and to develop tools and resources for practitioners and the public. So just a bit of background. When Canada announced we would be legalizing non-medical cannabis, it raised many questions and concerns about public health and safety, including cannabis-impaired driving. Many people wanted to know how Canadian drivers perceive the risks of using cannabis and when they think it would be safe to drive after use. So knowing what drivers think helps road safety experts improve targeting of public education policies and resources. So to help put into context some of the results we are going to talk about from our study, it's important to understand what the current evidence and public safety guidelines say. So although the study of cannabis and impairment is still evolving, we suspect that a person's biology affects how cannabis impairs, and we know that certain characteristics of cannabis products affect impairment differently. But until we have more science, the primary concrete evidence we have to educate the public is if you inhale or vape cannabis, wait a minimum of 6 hours before driving. And if you ingest cannabis, you should wait a minimum of 12 hours before driving.
So the data for this study, it comes from Statistic Canada's National Cannabis Survey. This is a nationally representative survey that collects waves of data at 3-month intervals to track changes in cannabis use patterns and behaviors before and after legalization. The sample size is roughly 6,000 for each wave, and there are currently 9 waves of NCS data. Our study focuses on 5 waves dating from October 2018 to December 2019. The majority of our analyses focus on people who reported cannabis use in the past 3 months, with the exception of one table where we look at frequency of use. And in that table, we include those who indicated no use in the past 3 months for comparison. The final sample size is approximately 3,890, and our N is rounded to base 10 to maintain confidentiality. 60.8% of the sample is male and 39.2% is female. We removed a small portion of cases who identified as non-binary because N was too small for the purposes of statistical inferences. The dependent variable in our analyses is perceptions of driving after cannabis use. The survey question asks, as far as you know, when is it safe for someone to drive a motor vehicle after using cannabis? And respondents were prompted to answer either in hours or to answer it depends on person and product. So to understand a bit more about who was most likely to answer depends on person and product, we also conducted logistic regression. So our analyses include both descriptive statistics and logistic regression models. So we're now going to talk a bit about some of our key findings. We looked at who was most likely to respond depends on person or product to the question of when it is safe to drive after using cannabis. These are some of our significant findings. For age, we can see that 25 to 34 years old, as highlighted in green, were the most likely to answer depends on person and product. 55 to 64 years old, as highlighted in yellow, were the least likely to answer this way, with 45 to 54 years old being the second least likely group. Females were more likely than males to answer depends on person or product. And people who use for both medical and non-medical reasons were more likely to answer depends on person and product. People who use for just non-medical reasons were the least likely. In terms of region, British Columbia was the most likely to answer depends on person and product. Prairies were the second most likely, and Quebec was the least likely. So from here on out, we're going to focus on people who reported that time was important in considering when it is safe to drive after cannabis use. We left the depends on person product response on the right of the tables for reference. And as this table shows, regardless of frequency of use, the most common answer given is depends on person or product. But when looking at those who answered in time, those who did not use in the past 3 months, as indicated by the blue bar with the red arrow on top, these were the most likely to believe that you need to wait 5 or more hours after using cannabis before driving. And so the likelihood of answering 5+ hours, it lowers as frequency of use increases. So if we follow the red arrow, we can see the slope from yellow being monthly use, to purple being weekly use, to green being daily or almost daily use. So as we go through the groups, the more frequently cannabis is being used, the lower the proportion is of those who indicated 5+ hours. So from this point on, we will now only be focusing on people who indicated using cannabis in the past 3 months. And again, the majority of respondents in each of the age groups believe that when it is safe to drive after cannabis use depends on person or product. But of those who answered in time, older respondents were more likely to think that it is safe to drive after waiting 5 or more hours. And this is illustrated by the red arrow where we see a steady incline. The yellow bar being 45 to 54 years old, and the purple bar being 65+ years old. These are the 2 age groups that were most likely to answer 5+ hours. But youth, particularly 15 to 24-year-olds who answered in time, the most likely response they were to give was 3 to 5 hours. So of those who answered in time, they were actually more likely to answer 3 to 5 hours than 5+ hours. And this is illustrated by the pink bar with the blue arrow. In terms of gender, just a reminder that we removed the non-binary category because the N was too small. Our findings suggest that females were more likely than males to think that the ability to drive a vehicle after using cannabis depends on the person and product than on time elapsed. But when looking at those who answered in time, females were more likely than males to believe that one must wait 5+ hours, as indicated by the red arrow. Males were more likely to believe that it is safe to drive under 5 hours than females, and that's indicated by each of the blue arrows that follow.
So we also examined whether the reason for a person's cannabis use, which could be medical, non-medical, or both reasons, was related to how they perceive when it is safe to drive. So keep in mind, these are self-reported reasons for use, and the survey could not confirm if someone had a medical authorization or was self-medicating. So as Nick mentioned earlier, people who use for both reasons, the yellow and orange bar on the very far right, they were significantly more likely to say it depends on the person and product when determining when it is safe to drive. However, among those who think that waiting a certain amount of time is more important to determining driving safely, individuals who used for only non-medical reasons or who used for only medical reasons, the blue and green bars, they were more likely to think one should wait at least 5 hours before driving. There were also noticeable regional differences. So when it comes to waiting before driving, with the exception of Quebec, the further east one lives, the more likely one will think that a driver should wait at least 5 hours. So for example, the Atlantic provinces, the blue bar on the right, they were the most likely to think drivers should wait at least 5 hours. What's interesting here is even though people from Quebec, the orange bars, think that waiting to drive is more important than depends on person or product, they're the most likely to think it's safe to drive within 1 to 3 and 3 to 5 hours of using cannabis. So to put this all together, we did examine other potential characteristics of people who use cannabis in driving, and these will be discussed in greater detail in our paper that we'll be putting together. But overall, it's clear that people who use cannabis are more likely to think that driving safely depends on the person and the product. So even still, among those who think that time is important, many still think it's safe to drive before waiting at least 5 hours or the recommended guidelines of 6 or 12 hours. So these findings have various implications. One is that it seems that the majority of people using cannabis, they're likely making personal judgments about when to drive rather than following the current public safety guidelines. So in this case, education needs to be more consistent among people who use cannabis. Another implication is that some of the differences in when people believe it is safe to drive appear to depend upon characteristics, so such as the frequency of use or the region in which they live. So this tells us that education needs to be tailored to these differences in order to reach people who need the information for these different areas. Lastly, based on this survey, we need to conduct more research to better understand the reasoning people are using who think it depends on the person and product. It's quite possible that some people are making appropriate choices, but it's also possible others are not, and we just don't know enough from this type of data. So with a better understanding of driver thinking, we can all help to educate and reduce driving impaired by cannabis. Thank you.
Thanks, Sean and Nick. That was very interesting. There's a lot of good stuff there. I don't see any questions for you in the Q&A just yet. Maybe there'll be some later on, so you're off the hook for the time being. And with that, we'll move right on to the next presentation, which is by Amir Razagazad. How did I do with that, Amir? Can you pronounce your name for us so that we get it right next time?
Yeah, that wasn't bad. It was Razagizad.
Oh, it's not too bad. Okay, you have 15 minutes. You're on.
Well, thank you very much for that presentation, or pardon me, that introduction as well. So my name is Amir Razagizad, and I'm a second-year master's student at the Center of Outcomes Research. and evaluation at the McGill University Health Center. And today I'll be presenting some prevention research that we did based on a systematic review for the prevention of drug-impaired driving. Now, this project is very important, as everyone can imagine, because motor vehicle collisions are a leading cause of death and injury in North America, resulting in more than 40,000 deaths and 2.5 million emergency department visits per year. And at present, non-medicinal cannabis for recreational use has been legalized in Canada, Uruguay, as well as 15 US states and the District of Columbia. And although alcohol has historically been at the focus of impaired driving, a lot of recent literature has suggested that the legalization of cannabis may have increased the risk of fatal motor vehicle collisions. For instance, a recent ecological study by Sarah Windle and colleagues showed that US states which legalized cannabis experienced a 15% increase in the rate of fatal motor vehicle collisions. And this finding is actually consistent with some of the other literature in the field. For example, interrupted time series analysis, which is based in Uruguay, showed that the legalization of cannabis was associated with a 52% increase in the rate of light motor vehicle fatalities. And as a result, the consumption of psychoactive drugs and road safety have really become an increasing public health concern in recent years. And overall, the results which I just shared, which highlighted the association between cannabis legalization and the increase in vehicle collisions, is actually quite accordant with the effect that psychoactive drugs have on psychomotor skills. And as you can see in this table, which comes from the World Health Organization, the negative effects of cannabis have been particularly well established. For instance, you can see that cannabis affects drowsiness, cognitive functioning, motor function, mood, lateral vehicle control, time estimation, and balance. So given these findings, the objective of our systematic review was to evaluate preventive interventions for drug-impaired driving based on measures of drug driving knowledge, attitudes, behaviors, traffic-related outcomes among adults and youth. Now, I'm going to take the next couple of minutes of the presentation to just briefly discuss how we conducted the systematic review and how we actually evaluated the quality of evidence that we came across. The first thing that we did was we developed a systematic search strategy with academic librarians at our institution. And as you can see, we searched 7 databases, which included Embase, Medline, PsycInfo, SafetyLit, Transport Research International Documentation, ProQuest, and the Web of Science. And after screening approximately 11,000 citations, we identified 28 eligible full-text articles that describe various preventive strategies for the prevention of drug-impaired driving. Because we identified so many interventions in our systematic search, we needed to develop an analytical framework to help guide our synthesis of the findings. And you can see the conceptual approach that we developed for a systematic review here. And what this shows is the hypothesized links between the 3 types of interventions that we identified and our outcomes of interest. And as you can see, the 3 types of interventions were educational, deterrent, and rehabilitative. And the intermediate outcomes that they connected to included improvements in knowledge about drug driving, the formation of negative attitudes and perceived risk of punishment, and finally, traffic violations and vehicle collisions, which led to the main outcomes of interest, fatal and non-fatal injuries. To evaluate the quality of evidence associated with the interventions that we came across, we utilize a really well-established framework known as the grading of recommendations, assessment, development, and evaluation approach, which is commonly known as GRADE. And as you can see here, the interventions in our systematic review could have evidence ratings which ranged from very low to high. For instance, you can see a high quality rating means that we were confident that the true effect estimates lie close to the estimates of the effect, whereas a very low evidence rating meant that the estimates of effect were very uncertain and were often probably far away from the truth. Now, for the remainder of the presentation, I'll be discussing the effective interventions that we identified. And generally, I'll be presenting population level interventions first, and then interventions which are best suited for healthcare providers. So for the population level interventions, some of the highest quality evidence that we identified came from a randomized controlled trial that evaluated the effect of health warnings on cannabis packaging. And this randomized controlled trial was conducted at the University of Alberta, and it enrolled about 650 students. And what the authors of the study found was that cannabis packaging that had traffic-related warnings were able to significantly increase participants' belief that drug driving is a harmful activity by about 6%. And you can see that this warning simply stated that the chance of motor vehicle accidents almost double while under the influence of cannabis. And this led the authors to conclude that health warnings were a cost-effective medium to communicate health information, given their reach and frequency of exposure at the point of purchase and during use. As part of our review, we also came across moderate quality evidence regarding the effect and impact of roadside drug testing. For example, we came across theoretical evidence in support of roadside drug testing, which showed that high certainty apprehension scenarios where the police could randomly test for drugs decreased cannabis users' odds of willing to drug drive by almost about 80%. And while this evidence was only theoretical, it was consistent with real-world data from Australia that showed that injection drug users who had been tested for drugs while driving more than once were about 40% less likely to have drug drive in the last year compared to individuals who had never been drug tested before. In the population level intervention category, we also found quite a bit of evidence regarding media campaigns. And this evidence came primarily from the UK and Scotland, where 2 anti-drug driving advertisements were aired for approximately 2 months. And what we found was that individuals who recognized the advertisements versus individuals who didn't generally perceived a greater likelihood of being stopped while drug driving, and generally also had a better understanding of the drug driving laws in the countries that they were living. And overall, these interventions were found to be quite cost effective as well, as they had a pretty wide impact. For the final population level interventions we identified, these generally had to do with state sanctions. And as you can see, the 3 state sanctions that we came across were the criminalization of road traffic offenses in Spain, the license withdrawal of drug offenders in the United States, and per se drug driving laws, which are biochemical limits of drug metabolites that constitute per se evidence of drug impaired driving. And the certainty of evidence for these interventions was generally very low. However, we did find that the criminalization of road traffic offenses in Spain was associated with a 7% decrease in the risk of traffic injury collisions among men. We also found that states which withdrew the licenses of individuals who had been caught or which withdrew the licenses of drug offenders had slightly less traffic fatalities per 10,000 miles than states who didn't implement these laws. And we also found that per se drug driving laws typically had no effect on traffic outcomes, as the effects were often null and inconclusive. Now, I'll be talking about the interventions which can be initiated, recommended, or provided by healthcare providers. Some of the highest quality evidence that came from this category came from evaluations of driver education programs. And here you can see that a driver education program called Safe Drivers Wanted, which was based in the US, was able to reduce the odds of drug driving among youth by almost 40%. And some of the key components of this intervention included reviewing risk-taking behaviors related to driving and helping parents develop a driving contract, which included negative consequences if their kids broke any of the agreements that they agreed on. In contrast, we found weaker quality evidence regarding the impact of drug abuse prevention programs for preventing drug-impaired driving. However, the best quality evidence that we did find came from a program called Life Skills Wanted, which focused on teaching students grades 7 to 9 different cognitive behavioral skills to build self-esteem, resist peer pressure, and communicate effectively. And an evaluation of this program found that participation was associated with a 20% reduction in traffic offenses after 6 years. However, the certainty of evidence was quite low for this type of intervention.
Amir, you've got about 4 minutes left.
That's perfect. Thank you. The next intervention that we evaluated was motivational interviewing, which we found to be one of the most effective strategies. And motivational interviewing was defined as a client-centered counseling style for eliciting behavior change by helping clients to explore and resolve ambivalence. And 2 randomized controlled trials, which evaluated motivational interviewing, found that it was able to significantly decrease cannabis-impaired driving by between 13 and 50% among youth who claim that they regularly use cannabis. And one of these randomized controlled trials actually showed that motivational interviewing was able to reduce cannabis-impaired driving 12 months after the initiation of the program. Finally, the last provider level interventions we identified were substance abuse treatment programs and driver rehabilitation. For instance, we found that substance abuse treatment programs were able to significantly reduce cannabis and cocaine impaired driving by between 10 and 26%. However, the findings were generally inconsistent with some of the other research that we identified, which led to the very low evidence rating. In terms of rehabilitation, most of the research came from Germany and Sweden, which somewhat limits generalizability to the Canadian context. However, a German program called Drugs did actually demonstrate some noteworthy findings. What they found was in their program was actually able to cut recidivism rates by almost a third 3 years after follow-up. And what this program consisted of was simply 4 4-hour group sessions where participants discussed the role of drugs in their lives in order to develop behavioral coping strategies to implement for about 5 weeks. Now, there are a number of unique challenges associated with drug driving and numerous potential avenues for future research in the field. One of the main challenges, which has been briefly touched on, is the fact that a lot of the research has implicitly relied on drunk driving. And this is somewhat problematic, as one of the unique challenges associated with cannabis, for example, is the fact that the perceptions of risk are usually substantially lower than for drunk driving. In addition, people generally report feeling more cautious when they're driving high and little fear of police involvement. So in conclusion, we found that there are effective interventions for intermediate outcomes, such as improving knowledge and attitudes about drug driving. But overall, data are generally significantly limited for hard outcomes, such as drug driving related morbidity and mortality. As a result, we believe that future avenues for research, future research should emphasize public education campaigns that target social norms and the perceived riskiness of drug driving, particularly among youth. And finally, I'd like to take the last couple of moments of this presentation to thank the Canadian Institutes of Health Research for funding this project and everyone else who was involved. Thank you very much.
Thank you, Amir. We're getting some questions here, so I hope we can get through the next couple of presentations in time to answer them. Otherwise, you'll have to just look at them and try and answer them yourselves later. So now, return engagement by Christine Wickens.
Let's see if we can get this to work this time a little bit faster. I think we're good. Okay, so this time I'm speaking on the potential impact of personality on the effects of cannabis on driving. So a number of personality traits and individual differences are associated with deviant on-road behavior, including driving after cannabis use. So for example, sensation seeking and impulsivity have been found to predict frequency of cannabis-impaired driving. And perhaps not surprisingly, many of these same personality traits are also associated with alcohol and substance use. A recent study by Dahlgren et al. 2020 identified an influence of impulsivity on chronic effects of cannabis on driving. Specifically, after 12 hours of abstinence, frequent recreational cannabis users and healthy controls with no history of cannabis use were tested on a driving simulator. Cannabis users were divided into early and late onset users, defined as those who started using cannabis before or after age 16. Results showed that even in the absence of cannabis, early onset cannabis users demonstrated greater risky driving than non-users, including missing more stop signs, stopping at fewer red lights, driving a greater percentage of distance over the speed limit, and causing more collisions. But interestingly, when impulsivity was included as a covariate, only the missed stop signs and collisions remained significantly different, suggesting that personality traits may impact the nature or the extent of the drug's chronic effects. So what do we know about the influence of personality on acute effects of cannabis? And the answer to that question really is not very much. And to my knowledge, none of the few existing studies really focus on driving. So in a sample of healthy polydrug users, Spronk et al. 2016 examined how the effects of cannabis on response inhibition, which is a measure of cognitive impulsivity, might interact with trait impulsivity and novelty seeking. And although both drugs produced effects on the go-no-go task, that measure of response inhibition, neither trait impulsivity nor novelty seeking was correlated with drug-induced effects. However, Vanuel et al. 2015 examined psychedelic symptoms of cannabis as a function of trait impulsivity. And in a sample of healthy drug users, 40% of whom were classified as having high impulsivity. Now, in their findings, on some of the measures, highly impulsive participants displayed stronger psychedelic effects than participants with normal levels of impulsivity. But a greater number of measures recorded no such difference. And so in the end, the authors concluded that drug users with high trait impulsivity were somewhat more sensitive to the psychedelic effects of drugs, but the influence of trait impulsivity was mild and restricted at best. So that's the background. The study I'm presenting today examines the influence of personality on the acute effects of cannabis as they relate to simulated driving. And specifically, I'll be looking at chosen speed. What I present today is really part of a broader analysis that examined a number of individual difference variables, but assessment of those other individual differences yielded no statistically significant findings. But if you are interested in that broader analysis, it was recently published in Experimental and Clinical Psychopharmacology. But today, again, we're going to focus on just one component of that analysis that I think is a bit of an interesting finding. So the current analysis is based on data reported by Brands et al. 2019 in a study that assessed the acute and residual effects of smoked cannabis on simulated driving. The study adopted a between subjects, placebo-controlled randomized design. Participants included healthy recreational cannabis smokers aged 19 to 25 years who held a valid driver's license. This analysis, the current analysis, focuses on those participants who were randomly assigned to the active cannabis condition, which included 44 males and 17 females with an average age of 22.2 years. Approximately 39.3% of participants reported using cannabis up to once per week, and 34.4% used cannabis 2 to 3 times per week. Now, prior to cannabis exposure, an indwelling intravenous catheter was inserted to collect blood samples throughout the drug exposure session. Cannabis smoking was performed in a dedicated reverse airflow smoking laboratory. Participants were instructed to smoke the cigarette until they reached their desired high for up to 10 minutes, and the end of smoking marked time 0. So the aim of the current analysis, again, is to examine the influence of personality on the acute effects of smoked cannabis on simulated driving. And to achieve this aim, the current analysis pulled specific pieces of data from the Brands et al. Study. So we've pulled self-reported data, including demographics, personality, and individual differences. We've pulled blood data. So we're looking at THC blood concentration 30 minutes after drug exposure. And we've also pulled driving simulator data collected before and 30 minutes after drug exposure. In terms of driver simulation, multiple custom driving scenarios were programmed on a rural highway with a posted 80 km/h speed limit. Participants were instructed to drive as they normally would. The main driving outcome variables were mean speed and lateral control assessed on a straightaway, which is a straight stretch of road without any traffic control signals or any other moving vehicles. Now, Brands et al. Reported a significant acute effect of cannabis on speed, but not on lateral control. And so as a result, the analysis I'm presenting today will focus on chosen speed. Simulated driving was assessed under both single task and dual task conditions. And the additional task that was completed by participants when doing the dual task condition was to count backwards from a number between 700 and 999 by threes while driving, which actually is a little more challenging to do than you might expect. But it's used, this type of task is used extensively to increase complexity and load of cognitive tasks. So the current analysis includes 3 well-validated self-report measures: Isaac's impulsivity questionnaire, the brief sensation seeking scale, and the general health questionnaire 12, which screens for indicators of depression and anxiety, which we will refer to here as psychological distress. And due to extreme non-normality in the distribution of the GHQ scores in this data set, the values here were converted to binary scoring. So we use linear hierarchical regression analysis, adopting a gain score analytical approach. So the outcome variable for the regressions was a derived change score. So in other words, we calculated it as a change in speed from baseline under either single or dual task conditions. The first block of predictor variables in the regression was the same for each model, and it included sex of the participant, THC blood concentration 30 minutes after drug exposure, and baseline speed. And then the second block of predictor variables was sensation seeking, impulsivity, and psychological distress. Now, as I noted at the beginning, a total of 6 regression models were tested, and I'm only presenting 2 of them today. But to control for type 1 error, or the possibility of type 1 error, the p-value for all of the regression models was assessed using a Benyami-Hochberg correction or adjustment, which used a false discovery rate of 5%. So did any of the personality variables predict reduction in speed under either single or dual task conditions? And here we have the answer. So the first model that you see here is the regression model for single task driving conditions. As you can see, the model is significant, and it accounted for 36% of the variance. Pre-drug speed was a significant predictor in the final model, as was impulsivity. And here we have dual task driving conditions. The final model was also statistically significant, this time accounting for 15% of the variance. And as with the single task conditions, both pre-drug speed and impulsivity significantly contributed to the final model. Okay, so these results demonstrate a greater reduction in speed after smoked cannabis among those drivers higher in trait impulsivity, even after controlling for pre-drug speed. So these results may suggest that individuals who are higher in trait impulsivity may be more sensitive to the driving-related effects of cannabis. Now, reduced speed is considered, it's a compensatory behavior that's initiated in response to subjective drug effects. Our results suggest that drivers high in impulsivity may be feeling the effects of cannabis more strongly, and thus demonstrating stronger behavioral effects of the drug. Here, we had an effect of speed. But what if we were to look at driving scenarios that had shown an effect of cannabis on weaving or reaction time? This has important implications for effective targeting of countermeasures. But let me address the limitations first. So this was, as I said, this was a secondary study. So the sample size here, we were using an existing project. We didn't power the study to do this analysis. We were using what was available. And so the sample size was restrictive, resulting in limitations to how we analyze the data. The sample itself may also have been restrictive. It included predominantly males with a high level of education. And finally, impulsivity was measured solely by self-report, but impulsivity is really a multidimensional construct. It can be assessed through self-report measures, which examine impulsivity as a personality trait, which is what we did here, or it can be assessed through task-based measures, which really focus on cognitive impulsivity, such as looking at response inhibition. And each test likely taps into one or a combination of the processes that actually underlie impulsive behavior. And so for this reason, our future investigations of this research question will include both types of measures. Now, a special note here, I wanted to make this note on the potential for interdisciplinary study, because it's why I really get excited about this research. Impulsivity is examined from a diversity of academic perspectives. So for example, in hunting for relevant literature, I found a few studies that note a reduction in behavioral response inhibition among chronic cannabis users, but those studies came from outside of my own discipline. So neurochemistry cited CB1 receptor agonists and dopamine, genetics cited endophenotypes and genotypes. There's so little data in any one field right now, at least for now, that you really have to look beyond your own discipline. And as challenging as this can be, the benefit is that it's really an impetus for scientists in diverse areas to converge and to work together, which is, it's a really exciting prospect. Okay.
Christine, you've got about 3 minutes.
Perfect. As I said before, our results have important implications. So they will inform our understanding of how cannabis affects driving and who is most vulnerable to these effects so that we can develop targeted prevention countermeasures. Anti-drug driving campaigns could be directed to those audiences who are most likely to include impulsive cannabis users. Toolkits and resources could be forwarded to parents of young drivers with impulsive tendencies, which potentially could include those with attention deficit hyperactivity disorder. But all of these implications require future research. So aside from replicating this finding, we need to assess the value of educational interventions on impulsive cannabis users. We need to assess the effects of impulsivity on other driving variables that are potentially affected by cannabis. And we need to explore if different symptoms or treatments for ADHD, for example, are differentially associated with effects of cannabis when driving. So there's lots of possibility here. Again, it was a secondary study that we used, but it's an interesting finding that I think is worth future investigation. So again, I thank you for your continued attention and welcome any questions now, or perhaps if there's time at the end. Thanks very much.
Thanks, Christine. Given the time and the fact that the annual general meeting is coming up immediately following this session, we should move right on. And I'm going to ask Barrington Hector and Sylvia Lark to talk to us about other factors associated with cannabis and driving.
Can you folks see the screen? Just testing this.
Yes, we can.
Without the speaking notes, I'm assuming?
No speaking notes.
Excellent. Okay. Good afternoon, folks. Hope everyone is doing well. Joining us from the various locations across Canada and no doubt the globe. My name is Barrington Hector. I'm going to start by thanking the conference organizers for having us here at this year's virtual conference. I'm the project manager for Weed Out the Risk. It's a springboard initiative that is, that is a harm reduction tool that really combats some of the things that earlier presenters were speaking about. I am joined today by Sylvia Lark, who is the project coordinator. As you can see from the screen, as I mentioned, we are a harm reduction tool to support youth education on impaired driving, and we are an evidence-informed program, evidence-based program. So, I was so happy to hear some of my colleagues earlier speaking about, some of the issues and challenges that are faced, and some of the things we can do as well. So, looking at interdisciplinary practice, as was just mentioned, is huge for us in the programming world. We would not be here without the good evidence that you folks provide. So appreciate that. Now, as a focus of the program, I'm just going to jump into our approach and strategy. We are a fully digital program in terms of our access. Folks with a smart board or other technology in the classroom can be fully interactive with the program. It's always led by a trained facilitator who receives training from our project coordinator, Sylvia Lark, in the use of the program and facilitation methods. We are a harm reduction, non-judgmental approach. Again, that's reflected in our training as well as our content development and curriculum development. Right now, we are delivering in person, virtually, and remote due to the pandemic, and the program is available in English and Francais aussi. The program focus, focusing on the right side of the slide here, is youth and young adults between the ages of 13 to 24, both a high school and community delivery to weed out the risk, or the French version, which is called Pot au volant, c'est pas trépante. Our scope is national, meaning we reach every province and territory in Canada, and we deliver in communities of all sizes and makes, so urban, rural, remote, and Indigenous communities as well. Now, I am not going to take you folks, because of timing, I'm not going to take you through the entire timeline here, but you can see that the program was developed in 2013 as a means to, again, combat impaired driving amongst youth. And during that phase, we were focused in the Greater Toronto area primarily. And during that 5-year period, we reached over 17,000 young people in the Greater Toronto area. In 2018, we saw a provincial partnership with the Ministry of Transportation of Ontario, which allowed for the train-the-trainer model, which we use currently right across the country. And then that same year, we saw a successful national scale-up of the program under a Health Canada contribution agreement to just do that, to scale the program nationally. And we have been quite successful in doing so, as you can see over the years. Our outreach numbers and in terms of the number of participants, and moving towards the end of this scale here, you see we are hoping to launch a successful third phase of the project. Now, in terms of our overall impact, in terms of youth reached, you can see to date, 180,000 youth have been reached from coast to coast to coast. That represents nearly 6,300 presentations at 1,800 locations. And we have trained over 850 facilitators through our train-the-trainer model. Now, I'm going to pass it over to Sylvia, who's going to cover what's covered in a Weed Out the Risk session.
Thanks, Barrington. Yeah, so one of the great things about the Weed Out the Risk workshop is that it's about 1 hour, and it's going to reach youth and really debunk a lot of the myths that they have around cannabis-impaired driving. Even the definition about what impaired means, for some folks that comes to a very easy definition, and for youth, as we saw in the previous presentations, they really look at, depending on the substance and the users, it can really change whether or not they're able to drive, in their opinion. And this is one of those things that we really want to debunk and clarify what exactly impaired means, to include being hungover, being burnt out, those after effects of using cannabis, a few hours later. We want to make sure that they leave the workshop having a good understanding of how cannabis impairs their ability to drive. It's not just a rule that's set out just because it's impairing, but what exactly about cannabis that affects certain regions of the brain that are responsible for operating a motor vehicle safely. And then we also go into the strategies and techniques to prevent impaired driving. If we spent the whole hour just telling them all the reasons not to drive impaired, this has been proven that this isn't an effective tool to actually changing behavior. But what is important is making sure that throughout the session, they actually have rehearsed what they would say in their own words that makes sense for them to prevent impaired driving. And that's relevant to who they might be having that discussion with, how they're going to communicate to a parent that they don't want their parent to drive impaired anymore is different than how they might communicate to a partner or friend. So we want to make sure they feel very familiar with how to have those conversations. And then as well, they're familiar with the legal, social, and financial consequences of cannabis-impaired driving. And of course, having a good understanding of that is really the foundation to knowing, how to make the right decision as well. So in order to have a workshop done, as Barrington mentioned, it is led by a trained facilitator. I run bi-weekly training sessions. They're 3 hours in length, and I train professionals all across Canada to deliver the program. This includes professionals who come from a healthcare background, legal background, such as law enforcement. We have community service workers like folks from the YMCA, John Howard Society. We have over 800 different community organizations represented over the last few years that I've been delivering the sessions. So it's really quite a wide scope. And in these sessions, we're reviewing the harm reduction principles. We're going over the program content. So Weed Out the Risk is comprised of 30 slides. And we want to make sure facilitators feel confident in how to deliver each of those 30 slides, and maybe even selecting, which slides they'll use and not use based on the group that they're working with during a session. And of course, now we've moved to online delivery when necessary, depending on the group. We want to make sure facilitators feel comfortable with how to use Zoom or Google Meets or Teams, whatever program and platform that they're using, that they're prepared in how to deliver a successful workshop using that platform. And of course, the final one is making sure that we have tools and resources. So no one's going to leave that 3-hour workshop being an expert in the legal consequences and the health consequences and be able to answer every question a youth has, but at least they will have an idea of where they can look for appropriate resources to find the answers that youth are looking for.
Excellent. Thank you, Sylvia. And folks, I'm just going to quickly touch base on our fairly robust evaluation efforts under the national scope of this project. Now, as you can see, our evaluation design was quasi-experimental. We use post-presentation and 3-month longitudinal follow-up surveys. And then we also looked at retrospective historical to inform the work that we were doing on our surveys as well. In terms of the methods, we use both qualitative and quantitative methods, including document review, monitoring data from our surveys, and then looked at also some key informant interviews and focus group discussions with educators and youth alike. And just to be informative there, our key informant interviews included folks from our National Advisory Committee, which included leaders from law enforcement to public health and research as well, just to note. You can see our baseline data there. We used our partners at Mad Canada, one of our large partners, their school assembly data, which represents thousands of surveys to really guide the work we were doing in terms of our findings. And then, as you can see, we did a pilot survey in 2019, which ultimately informed the final version of our in-class and 3-month follow-up surveys. Now, Sylvia will touch base on some of the findings quite quickly.
So the surveys are given to students after a workshop. There's the immediate survey that they'll fill out right after a workshop, and there's the 3-month follow-up. This is really looking at, did the students have a change in behavior? That's a really important thing that we're really trying to evaluate here, is not only did they learn the information, but is it actually going to help them make the right decisions moving forward, not just for the next day. So what we found from this evaluation program that we did through the surveys was that 90% of participants said they had an increased awareness about the consequences of driving under the influence of cannabis. 89% of youth said they had a better understanding of how cannabis affects them, and 84% of participants reported that they knew more about how cannabis affects their ability to drive than before the presentation. So it's really important with the youth that We make sure that we're using the same language. We want to use language that's familiar to them, and it doesn't have any sort of judgmental tone. There's youth in the room who could have parents who work in the industry, or maybe their parents or themselves are prescribed medical cannabis. And so if we walk into a workshop and we're using language that makes them feel othered or maybe targeted, then that's going to create some distance and actually prevent good learning happening throughout the workshop. We want to make sure that the educators, this includes teachers who might be in the room during a presentation, gain knowledge from the presentation so that they feel well informed on how to answer future questions that the students may have even after leaving a workshop. And the results that we found is that it also has increased the word of mouth. So Weed Out the Risk is unique in that, unlike assembly programs, which Mad Canada runs as well, Weed Out the Risk is always using small groups. So we have a maximum of a classroom size, so that's usually around 30 to a max of 40 students. And when students leave the workshop, they're actually sharing what they've learned with their peers outside the classroom.
Sylvia, you got about 3 minutes.
Thank you. So once a facilitator is trained with how to use Weed Out the Risk is actually located online through Springboard's Community Learning Hub. Now, the Community Learning Hub offers various other modules for community service workers. These other modules could be very important for reaching other goals and working with their clients. So once you complete the Weed Out the Risk training, you actually gain access to all these other modules, which could be beneficial for the type of work that you do.
Perfect. And at this time, with time to spare, we'll open it to any questions that folks may have.
Okay, I'm just looking at the questions under the Q&A that have been posted. I don't see any that are directed towards you guys yet, but there are a few.
Oh, sorry, Doug. I was just going to say, folks can always check out, our booth in the exhibitor hall and ask us questions there if they do.
Great. I will encourage each of the presenters to have a look at the Q&A because you have the opportunity to respond by typing the answer into the space where it's indicated. I know some of the earlier presenters, there were questions there that we didn't get around to due to time limitations, but I think at this time it's about the hour that we should be headed towards the annual general meeting if you're interested, and I welcome everybody to go. Once again, thanks to all the speakers who put in the time and effort to share their work with us this afternoon. It's much appreciated, and we'll see you again soon. Thank you.
Thank you.